Hello everyone, this is Dr. Simanthini, your mentor from Study Medic, and today I will be discussing some important topics in subfertility for the forthcoming MRCPI written OBG exams. Okay, so starting with the quote of the day, think big, trust yourself and make it happen. So that means that if you dream big and you believe in yourself, then everything will fall in place. Okay, so let's start with first of the topic, that is male subfertility. Now a question is, a 34-year-old man presents with primary infertility for 3 years. His wife's fertility investigations are normal. Semen analysis reveals azoospermia. Hormonal profile shows raised FSH, raised LH, and low normal testosterone. So, what is the most likely diagnosis? Pause the video for 5 seconds and think once. Okay. So, to see this, we need to go and see for the physiology, that is testicular physiology. Okay. So if I point towards the testicular physiology and see how it is seen, you can see that hypothalamus secretes the GnRH and it controls the anterior pituitary LH and FSH. Okay. Now this is the pre-testicular phase. Then comes the testicular phase. In testicular phase, here there are interstitial cells and Sertoli cells. LH controls the interstitial cells and FSH controls the sustentacular or Sertoli cells, and then the final step and maturation occurs, and then finally spermatogenesis happens. So this is the testicular phase. After the testicular phase, when sperm production happens, then in the epididymis, vas deferens, here if anything happens, if any mechanical obstruction happens, then it is known as post-testicular phase. So how it happens? If FSH and if you see the hypogonadotropic hypogonadism, that is the pre-testicular phase. If FSH is decreased, LH is decreased, and testosterone also is decreased. That means it is a pre-testicular phase. In testicular phase, you can see that if there is no negative feedback from FSH or inhibin to the anterior pituitary, then what will happen? There will be continuous increased FSH, increased LH, and no testosterone production will be happening. And this is known as the testicular failure or testicular phase, which we are discussing. And if everything is normal, that is, the whole hormonal profile is functioning normal, but there is some mechanical obstruction which is happening, then FSH is normal, LH is normal, testosterone also is normal, but still we cannot see any sperm in the sample. That means it is a post-testicular phase. So that is why, coming to our question, if we see that what is the most likely diagnosis, here you will see FSH is raised, LH is raised, and testosterone is low normal. That means it is a testicular failure. So the correct answer would be primary testicular failure. Okay, so let me discuss some of the important causes which can happen for the male subfertility. So pre-testicular causes, what will be the question framed accordingly? If you see the pre-testicular phase in the congenital, you can see questions covering Kalman syndrome or hemochromatosis or any pituitary tumor might be given. Okay, if it is an acquired phase of pre-testicular, then there is a chance that they will be discussing something around drugs or hormones, specifically anabolic steroids, because testosterone will be given continuously. So there will be continuous negative feedback, and that is why there will be decrease FSH and decrease LH. Okay, so pre-testicular phase, anabolic steroids also is a very important SBA that might come. Okay, remember, SBA for anabolic steroids. Okay, now coming to testicular phase, that is congenital, you can get questions in the Klinefelter syndrome, or important questions you can get related to acquired ones, that is varicocele. Okay, so varicocele can also come as a question, remember. And in the post-testicular phase, mostly you will see questions coming as normal FSH, LH, and testosterone, and there will be some of the genetic disorders like cystic fibrosis or any congenital bilateral absence of vas deferens. Okay, So our question was related to primary testicular failure. Our correct answer was primary testicular failure, and common causes are Klinefelter's chemoradiotherapy, undescended testis, as we already discussed. And to summarize, hypogonadotropic hypogonadism is low FSH and LH, and obstructive azoospermia is normal FSH and LH. Okay, now let's see what are the few investigations which we can do to see to rule out the male subfertility. The main important thing which can be done in the general practitioner or in a regional level is the semen analysis, and this should be the WHO reference values. Okay, so volume is more than 1.4 ml, concentration is more than or equal to 15 million per ml. Please remember this, you have to by heart. Sometimes the reference values are given, and sometimes if the question comes in the semen analysis, then you should remember the normal values. Okay, total motility is more than 42%, and normal morphology is more than 4%. So how we will discuss with the male patient what they need to do. They need to have a 2 to 7 days abstinence is recommended prior to giving the sample. Okay, why? Because if there is a shorter period, the negative impact will be on the sperm count, and if it is a longer period, the negative effect can be on the motility. So you have to give them a proper abstinence. Okay, after semen analysis is seen, what are the definition of terms of the abnormal semen? So azoospermia is no sperm present, oligospermia is less than 15 million count, severe oligospermia, very important, less than 5 million per ml, asthenozoospermia, absent or low motility, and teratozoospermia, excess of abnormal forms. Okay, so if you see the second point of the RCPI guideline, it is written, in the case of any initial sample with results outside of the normal range, a further sample should be offered at a 3-month interval. That means only one sample is never sufficient. You have to repeat it after 3 months. And in case of severe oligospermia or azoospermia, the sample should be repeated or should be sent earlier. Okay, that means as soon as possible. Okay, now after you do the semen analysis, what other investigations we can do? Now these investigations are may be indicated and requested by a fertility specialist in conjunction with the andrologist. This is what our CPI guidelines say. So when they find out that there is some problem in the semen analysis, then a fertility specialist consultant is taken, and then they recommend the hormonal levels, genetic testing, ultrasound, okay, or even biopsy. So we have already discussed regarding the gonadotropin values. Let us discuss regarding the genetic testing. So if as I discussed previously, that if there is a severe oligospermia, that is less than 5 million per ml, or if there is an azoospermia, okay, if there is an azoospermia, then what will happen? This azoospermia one, then we have to go and do the most common abnormality of this can be azoospermia, can be Klinefelter syndrome. Okay, and if it is a non-obstructive azoospermia, after doing the karyotyping, what you will do? You will do a Y chromosome microdeletion also. And if it's an obstructive azoospermia, then you have to do cystic fibrosis carrier screening also. Okay, so this is a very important thing which I want to discuss, that if it is less than 5 million, and if it is a non-obstructive azoospermia, and or it's an obstructive azoospermia, first you have to do is karyotyping, and after karyotyping, in cases of non-obstructive azoospermia, you have to do and the Y microsome chromodeletion test, and in case of obstructive azoospermia, if you're suspecting, then you have to do a cystic fibrosis screening. Okay, now coming to the other tests which we can do, that is the imaging. This also can be done, and it can be through two modes. It can be through the testicular mode, or it can be to the transrectal mode. So if we are doing the testicular mode. What we are looking for? We are looking for testicular tumors, any microlithiasis, or any varicocele. And if we want to see the obstruction in the epididymis, vas deferens, so we have to do a transrectal ultrasound, which is very useful in investigating ejaculatory duct obstruction. Okay, so this is important. And if all the tests are done and the patient wants to have his own sperms and we need to detect if any sperm are available, the best option is to go for ICSI. Okay, that is biopsy followed by ICSI. Okay, so this is very, very important. You have to remember. Now, how to go ahead and manage the subfertility. So, medical management mostly is given in the first case, that is the hypogonadotropic hypogonadism. According to the NICE guidelines, what should be offered? Gonadotropin drugs should be offered. Okay, so that if you give them in a pulsatile mode, that is, if you give FSH, or if you give gonadotropin pumps and wait for 3 months, 6 months to then see the sample, then there is a chance that we might get some sperms in the sample. Okay, but if you see any idiopathic semen abnormalities, like if you see only one, that motility is less, or sometimes morphology says 3%, so you will not try to treat it according to the NICE guidelines. You will not not offer them anything like anti-estrogen, gonadotropin, kryptin, bromocriptin, kinin enhancing drugs. Nothing you will offer. Even if there are any antibodies, anti-sperm antibodies, NICE does not recommend systemic corticosteroids. And even if there is any leukocytes or in the semen, then also blindly we should not offer them any antibiotic treatment unless there is an identified infection, because there is no evidence that it improves the pregnancy rates. Okay, so how we will go ahead and manage surgically, like we discussed regarding the post-testicular causes like varicocele, any ejaculatory duct obstruction, epididymal blockage. So this can be offered a surgical correction according to the NICE, but it's an alternative to surgical sperm recovery and IVF. So if the patient is seeking fertility, always we can offer them first surgical sperm recovery followed by ICSI. And if we are discussing the risks and benefits and patient wants to go for surgical correction, then we can offer them in cases of obstructive azoospermia surgical correction. And remember a very, very important SBA, which I need to highlight. This is a very, very important SBA, as I told about the varicocele, because men should not be offered surgery for varicoceles as a form of fertility treatment, because it does not improve pregnancy rates. So this type of question can come, remember, and you have to see that in varicocele, we will not offer them any surgery unless symptomatic. Okay, and that too andrologist will decide. Now coming to this flow chart, this is only the summary which we discussed earlier. So if there is at least one abnormal semen analysis or abnormal male reproductive history, remember to have a complete male evaluation with history and physical examination and semen analysis. One semen analysis is done. If it is an oligozoospermia, normozoospermia, azoospermia, you have to order the gonadotropin to see the condition, whether which category it falls. And if it is an normozoospermia and any of the factors are abnormal, then you can have a discussion, and treatment of abnormal factors or management with assisted reproductive technology can be offered. If it is an oligozoospermia, then what you have to do after initial hormonal management, you have to discuss with the andrologist and fertility specialist and discuss regarding the management. And if it is an azoospermia, as I discussed, it's a non-obstructive case, then non-obstructive azoospermia, then Y chromosome microdeletion, and offer them micro TC and ICSI. And if it's an obstructive azoospermia, then genetic testing for cystic fibrosis, and again offer them microsurgical sperm retrieval and ICSI. Okay, so this is all about male subfertility. Moving on, let us discuss an important topic and new recommendations in RCPI, that is fertility investigations. Now, this question is: a 37-year-old woman and her 39-year-old partner present to the GP. They have been trying to conceive for 7 months. She has regular cycles, no past medical history, and no pelvic surgery. The partner has no known fertility issues. And according to RCPI NICE recommendation, what is the most appropriate next step? Okay. So to solve this question, you have to see first the age of the women and the partner and how long they have been trying. So let's see how it is going on. Okay. So if you go to the guideline in the RCPI fertility investigations, you will see the referral pathway. In the referral pathway, if the female age is less than 36 years and a couple has been trying for more than 12 months, then we have to offer them investigations. Okay. And if the female age is more than or equal to 36 years and they have been trying for more than or equal to 6 months, then we have to offer them investigations. So always remember the age group and the months they are trying. Okay. Then it will be easy for you to solve the question. So once remember in RCPI, the couple has to go to general practitioner, and that too they have to go simultaneously, and then only they will be given, or they will be having history examination, their proper counseling at the general practitioner level, and he or she will decide that whether to refer her to the 6 regional fertility hubs in the Ireland system. Okay. So once they meet the referral criteria according to the age, and if there is a known cause of fertility like azoospermia or absolute uterine factor fertility, then there will be a history and further investigations. And what are the investigations? AMH levels, transvaginal ultrasound, and semen analysis. Once this is complete, then a consultant appointment is fixed at the regional fertility center, and they will decide whether to go for conservative management, further investigations, reproductive surgery, ovulation induction, or to refer them to a tertiary center or onward referral to assisted reproductive therapy. So this is a summary. So there are 3 stages of national model of care for infertility. Primary care starts with the GPs. That is the first point of contact for couples. This is the same as the NICE guideline, remember. And secondary care starts with the regional fertility hubs. Okay, initial consultation and investigation, and then tertiary care or advanced assisted human reproduction is mostly offered through primary infertility clinics in Ireland. But from January 2025, there has been few guidance regarding who can access the public fund, and I'll discuss it in the next slides. Okay, so according to our question, what we discussed is that if you see the question again, that this 37-year-old woman, 39-year-old partner trying for more than 7 months. So what we have to do? Start fertility investigations now. Okay. So because she is more than 36 years and she has been trying for more than 6 months. Okay. So moving on, what are the investigations for women which we need to recommend? According to the RCPI, if the woman is having a regular menstrual cycle, routine testing for ovulation is not recommended. If we want to confirm ovulation, then it can be done through mid-luteal progesterone testing or through urinary luteinizing hormone kits or a transvaginal ultrasound. Okay, so these 3 methods can be used to confirm the ovulation. If supposedly the ovulation cannot be confirmed, okay, then what you can do is you can on day 2 to 4 of the menstrual cycle, you can offer them for FSH, LH and estradiol. This is according to the best practice, and this is only for the RCPI recommendation. It is not given in NICE. Okay. Now, second is after ovulation confirmation, what we need to do? We need to see the ovarian reserve testing. And according to NICE, according to the best practice by RCPI also guidelines, the main important things are the anti-Mullerian hormone, that is AMH, and the antral follicle count, that is AFC, which is the best as ovarian reserve testing. Okay. Now, moving on, what other investigations we can do? We can offer her a baseline transvaginal pelvic ultrasound scan, and it should ideally be performed in the first 10 days of cycle. Okay, it should be performed with a high frequency transducer, 5 to 8 megahertz, and in the first 10 days, remember. Okay, and what other tests we need to do? Because we have seen the uterus, we have seen the ovaries. So what we need to do? We need to see the tubes also. So tubal patency, according to the best sources available, can be done through HSG, that is hysterosalpingogram. And if we have a trained person, we can also do a high COSI because they have a good specificity and sensitivity rate. Now, provided there is no pelvic pathology, it is very, very important. Why I'm saying this? Because if there is a previous ectopic pregnancy, okay, or if there is an endometriosis, okay, or if there is any PID, if there is any endometriosis, or if there is any previous ectopic pregnancy, you will directly go for laparoscopy and dye test. You will not offer them HSG in such cases, and this is a very important test, BA. Okay, now other investigations which RCPI say is that if you see that as a woman is presenting with infertility, we can also offer her TSH testing. Okay, now moving on to next question, that is access to ART. So, a 36-year-old woman and her 38-year-old partner present to the GP requesting referral for publicly funded IVF in Ireland. She has no children from her current relationship but has a 10-year-old child from a previous marriage. She is a non-smoker. BMI is 28 kg per meter square and drinks 1 to 2 units of alcohol once a week. She underwent one previous IVF cycle privately with no embryos remaining. So, what is the most appropriate next step? This can be a probable question because in the fertility investigation guidelines, guys, you will see that there are few criterias which has been stated from January 2025. So eligibility criteria to access the RCPI public fund are that they must be the resident and they should be referred by GP. Second, they should not have any living children from the existing relationship. So if they have a child from previous relationship, that is fine, but not from the existing relationship. Then if they have undergone an IVF, but there are no embryos, they can still access one cycle IVF funding. Okay, and most important is the age. It can come as an SBA. Age of the birthing mother should be less than or equal to 40 years plus 364 days, and male partner should be less than or equal to 59 years 364 days. And the next is both in a NICE guideline and in RCPI, the BMI is very important, 18.5 to 30 kg per meter square. And lifestyle also, smoking as well as recreational drugs should not be done for more than or equal to 3 months. And also alcohol limits is 2 units per week. So you have to remember this. These are few of the charts which you should go through the RCPI guidelines to see what are the eligibility criteria. So this patient meets all the criteria. So that is why we will refer her to local regional fertility hub for assessment. Okay, fine. Now, let's move on to another important topic which can come is endometriosis and fertility. Now, here you will see a 35-year-old woman with a history of bilateral ovarian endometriomas is planned for ovarian stimulation and egg retrieval for fertility preservation. Her AMH level is low, which is the most appropriate management. Okay, here see the question. She is 35. She has a history of bilateral ovarian endometrioma. She is already planned for stimulation and egg retrieval, and her AMH is low. So, what does RCPI guideline recommend for endometriosis? There are 3 golden rules for fertility preservation. That is, avoid ovarian cystectomy before stimulation unless pain or retrieval issue. Okay. Second is always advise fertility preservation before surgery if there is bilateral endometriomas, stage 3 and stage 4 endometriosis, low ovarian reserve. Okay, and aftercare should be continuous medical suppression until ready for conception. Okay, so if you see in our question, we have to if this we have to tell her that we need to avoid a cystectomy unless required for pain or access to follicles. This chart I have taken from TOG article Endometriosis and Subfertility. Here also it is mentioned practical advice for considering fertility preservation in women with endometriosis is to avoid ovarian cystectomy unless indicated for pain or access to the ovary for oocyte retrieval. Now, what are the other things which the RCPI endometriosis also recommend when to operate? If it is a stage 1 and stage 2 endometriosis and you want to improve the pregnancy rates, then you can offer her operative laparoscopy. Okay. And in mild endometriosis, after that, you can offer them intrauterine insemination with ovarian stimulation. And whenever you are discussing endometrioma cystectomy, you have to consider before operation whether there is a good ovarian reserve, whether she is symptomatic, whether ART is planned, or whether there are no previous surgeries. Then only you should discuss regarding the operative procedures. And if it's a deep infiltrative endometriosis, then you have to offer her laparoscopy if there are symptoms as well as infertility and if the patient prefers. Okay. No, so in stage 1 and stage 2, to summarize, you can offer the operative laparoscopy plus IUI and ovarian stimulation. And in cases of endometriosis, along with other factors such as tubal problem like hydrosalpinx or male factor infertility or failed other treatments, you can directly offer them IVF and ICSI. Okay, so this is the last important topic, that is ovarian hyperstimulation syndrome. The question here is, a 30-year-old woman undergoing IVF presents 8 days after oocyte retrieval with abdominal distension and shortness of breath. She has marked ascites on examination, oliguria, that is less than 300 ml per day, and an ultrasound showing bilateral enlarged ovaries measuring 13 centimeter with ascites. Lab shows hematocrit 0.47, sodium 130 millimole, and serum albumin. Okay, so there is hyponatremia, hypoalbuminemia, hematocrit is raised, oliguria is there. She has marked ascites and she's 30-year-old and presenting after 8 days. So what is the most appropriate next step management? So for this, you have to categorize that according to RCOG classification, which category of OHSS this is. So I will do a brief recap of OHSS for this. Now, if you see the OHSS pathology, early OHSS is within 7 days after the HCG injection, and late OHSS is typically within 10 or more days after the HCG injection. And the most common chief that is a factor because of which this hyperstimulated ovaries produce pro-inflammatory mediator is the vasculoendothelial growth factor. This is also a very, very important SBA. You will find on that vasculoendothelial growth factor is the most important pro-inflammatory mediator for causing OSS pathophysiology. Okay, so this you have to remember. And what are the most commonly associated features if the woman is young? Polycystic ovaries, previous OHSS, high follicular phase LH, high dose of gonadotropin stimulation regimens if we are using GnRH agonists mostly and not using GnRH antagonists, or there is a multiple follicular response with stimulation, or there is very high estradiol levels, sometimes more than 20,000 picomole, and there is an exposure to HCG as a trigger of luteal support instead of GnRH as a trigger, or there is a conception which has happened, and moreover, supposedly if it's a multiple pregnancy, then also all these causes can have a higher chance of having OHSS. This is a very important slide, and one of the questions can come which are the causes for OHSS, or which is the most common, what among this is the most common cause of OHSS. Okay, so how does RCOG has classified the severity of OHSS? If you see in the question that only bloating and pain is given, only bloating and pain is given, then and ovarian size is less than 8 centimeter, then it is mild OHSS. If you see in the question that nausea and vomiting is also given along with pain, nausea, vomiting. Remember, nausea, vomiting, 8 to 12 centimeter, moderate OHSS. And severe OHSS on clinical examination, ascites is there. Along with all the lab values which we are reviewing is hematocrit is raised, hyponatremia, hypoosmolality, hyperkalemia, ovarian size is more than 12 centimeter, then it is a severe OHSS. This is what is there in case of our question. So she has been, the question which we discussed is a case of severe OHSS. And what is critical OHSS? When there is tense ascites, large hydrothorax, and raised hematocrit, raised white cell count, along with very important things like thromboembolism, acute respiratory distress syndrome. So if these are there, then it is termed as critical OHSS. Okay. So this table I have taken from the recent TOG article 2025. So as we classified according to the clinical features and lab features, mild, moderate, severe and critical OHSS, how to manage them. So if only pain and bloating less than 8 centimeter, you can go for outpatient management. If the patient is ready for follow-up, review her every 2 to 3 days, monitor her fluid balance and monitor her for deterioration. If the patient is presenting with nausea and vomiting and her ovarian size is between 8 to 12 centimeter, then you have to consider low molecular weight heparin also, an outpatient unless poor oral intake. Okay. And severe OHSS, as the patient was in our case, clinical ascites, raised hematocrit, ultrasound showing more than 12 centimeter, then how she has to be managed? Inpatient, remember. And what we need to do? Daily review, low molecular weight heparin, analgesia, rehydration, paracentesis only if there is marked ascites. Now here, very, very important thing to remember is that in analgesia part, you will not offer NSAID. Not offer NSAID. This you have to remember. Only you can offer is paracetamol and codeine as an analgesic. This is also very important SBA that can come. Okay. Another important thing is in critical OHSS, you need to give her ICU care. And you need to have a multidisciplinary team management for critical OHSS. Okay. Now, moving on. So our case was severe OHSS. So that is why what we did, we admitted the patient and low molecular weight heparin and fluids were started. Okay. Now coming to other important SVAs which can come for ovarian hyperstimulation syndrome. So if you are sending the patient home as an outpatient management, that is in mild and moderate cases, then what you need to see that she needs to review properly, and you need to tell them the vigilant signs which are important, like abdominal distension, pain, unable to have oral intake, unable to drink, okay, shortness of breath. This all needs, you need to remind them. Apart from that, as a clinician, what you need to see, whether there is any tachycardia, hypotension, reduced urine output, weight gain, increased abdominal girth, and in the lab parameters, hematocrit is increasing. So if all these things, whenever patient is reviewing and she is having an OHSS, and if you find anything critical, then you have to have an inpatient management for this type of patients. So what is the criteria? For inpatient, unable to achieve satisfactory pain control, unable to maintain adequate fluid intake due to nausea, show signs of worsening OHSS despite outpatient intervention, unable to attend for regular outpatient follow-up, and have critical OHSS. So all these things are very, very important to be taken care of. And remember, one of the question might come that it is a case of severe OHSS and she is insisting on having an outpatient management. So this is, if this is a dilemma, you can offer them outpatient management, but they have to be reviewed daily then. Okay, they have to be reviewed daily, remember. Okay, so what are the indications for paracentesis? Another important SBA that might come is if there is abdominal distension and pain is there secondary to ascites, or if respiratory compromise is there, and despite you are doing all the measures, or if you are doing all the adequate replacement, volume replacement, and still there is reduced renal perfusion, then under the ultrasound guidance, paracentesis should be offered. And this table I have taken from TOG article, how to lower the incidence of severity of OHSS. So this starts before only. Okay, so before only you have to offer the patient antagonist protocol. Start with the low dose gonadotropins. If high risk patients are there, you can directly start with minimal stimulation protocol like with letrose. And if you're planning for a GnRH agonist protocol, then you can offer them metformin. So before treatment only, few things if you consider, then it will help in preventing OHSS. Now during treatment, what is the recommendation? Best is to have a continuous ultrasound surveillance. Okay, and GnRH agonist for trigger. If you are taking a GnRH antagonist protocol, then you have to give them GnRH agonist trigger. Okay, so this is recommended for all patients showing signs of ovarian stimulation, that is more than 20 oocytes, or E2 levels more than 3500 picogram per ml. Very, very important. Okay, now after treatment, the best is embryo cryopreservation. This is a strong evidence that avoiding a fresh embryo transfer, so we want to prevent the late OHSS. Okay, we want to prevent the conception. So this is a strong evidence that avoiding a fresh embryo transfer and cryopreserving embryos significantly reduces the risk of moderate to severe OHSS compared with the fresh embryo transfer cycles. Now dopamine agonists also have been recommended who had HCG trigger or have signs of OHSS. Okay. So this you will also see in the OHSS RCPI guideline. Okay, you will see that they are giving dopamine agonist cabergoline 0.5 milligram per day for 5 to 7 days may be prescribed to the woman at high risk of OHSS. Other things which RCPI also mentions is antagonist protocol. So we have already seen the slides. What are the risks which can cause OHSS, like young women, okay, less BMI. So all these patients should be having PCOS, should be given antagonist protocol because they're at high risk of OHSS. And venous thromboembolism prophylaxis should be given to women who develop OHSS. This is also a very, very important SBA. Where does thromboembolism mostly occur in case of OHSS? It is in the upper limbs. Okay, so whenever you think that OHSS is there in case and venous thromboembolism in there in case of OHSS, you have to give low molecular weight heparin. Okay, so these are few of the 5 questions which we discussed, very important tables and charts, and I hope that it will be helpful to all of you guys in just going through all of these questions. Okay, it's never too late to be what you might have been. Okay, I know every one of you is well prepared, and all the best for forthcoming MRCPI exams. Thank you so much.